Usually when we talk about a medical diagnosis, there is this underlying expectation of anatomical precision, you
Oh,
know?
right, yeah, like a comforting binary.
Exactly. Like you break your arm, the x-ray shows a very jagged, undeniable white line right across the radius, and the attending just points at the screen and says, well, there it is. That's the problem.
Yeah, the bone is broken or it's intact. The clinical path forward is, highly visible and cleanly categorized.
But the moment you step into the world of neurocritical care and traumatic brain injuries, that pristine x-ray machine metaphor just it shatters entirely.
Oh, completely. It is the absolute definition of diagnostic muddy waters.
Right, because you can't just put a cast on a concussed cerebral cortex. We're looking at a landscape that is incredibly murky.
We're dealing with these microscopic cellular cascades, electrical storms, and neurochemical shifts that just don't neatly show up on a standard CT scan.
But they absolutely dictate whether the patient will ever fully recover.
Exactly. So imagine you're standing at the bedside right now. You're managing a patient who has just suffered a moderate to severe traumatic brain injury.
A pretty common scenario on the ward. Motor vehicle accident, cerebral contusions, maybe a small subdural hematoma.
Yeah, and because of that sheer physical trauma to the delicate architecture of the brain, this patient is sitting at a remarkably high risk for early post-traumatic seizures.
And a seizure in this specific window is just a catastrophic complication, isn't it?
It can drastically derail their entire neurological recovery.
Yeah.
I mean, a grand mal seizure dramatically spikes the brain's metabolic demand.
Right, it's flooding the tissue with a need for oxygen and glucose.
Exactly, at the exact moment when the injured brain is dealing with compromised blood flow. It just can't afford that energy expenditure.
So, relying on current neurocritical care guidelines, you write the standard order for prophylactic antiepileptic drugs, or AEDs, to keep that electrical activity suppressed.
Right.
But then comes the central question, the one every single clinician faces when they're rounding on these patients a few days later, just looking at a stable monitor.
How long should we actually continue these prophylactic AEDs to prevent early seizures?
Exactly when is enough enough?
That is the crucial decision point, where our protocols often collide with clinical anxiety. So our objective today is to completely dissect that standard 7-day protocol.
Okay, let's unpack this. We need to explore the specific biological mechanisms that make 7 days the magic number, right?
Yes, and analyze why our own clinical instincts, our deep desire to protect the patient, frequently betray us into extending this treatment unnecessarily.
And then clearly define the non-negotiable clinical triggers that actually justify deviating from that default plan. Let's start with the absolute foundation of this rule.
Okay, yeah. Before we can even entertain the idea of extending a patient's treatment, we really have to understand what that standard 7-day course is actually accomplishing on a cellular level.
So the default posture is exactly 7 days of prophylactic AEDs following a moderate to severe TBI.
The standard absolute default clinical posture. And this isn't just some random number a committee pulled out of thin air because it equals 1 week.
Right, there's actual biology behind the calendar.
What's fascinating here is that this 7-day window specifically covers the most critical biological period for early post-traumatic seizures.
To understand why, you really have to look at what's happening inside the cranial vault during that first week.
Precisely. The secondary injury cascade. The initial physical impact shears the axons and bruises the tissue, but, that's just the beginning.
Over the next few days, the brain experiences cytotoxic edema, right?
Yeah, because the cells are damaged, their internal ATP-driven energy pumps fail. They can't regulate their ions, so sodium rushes into the cells and water just follows it.
And the brain cells themselves physically swell up like little water balloons.
Exactly. And while that's happening, the blood-brain barrier is breaking down.
Which is usually this highly selective security fence that keeps systemic toxins and inflammatory markers out of the brain fluid.
Right, but now it becomes highly permeable. So you have swelling neurons, systemic inflammatory cytokines leaking into the brain, and a massive neurochemical storm.
A storm of excitatory neurotransmitters, primarily glutamate, just being dumped into the extracellular space.
And that creates an environment of extreme electrical irritability. The risk of a seizure being provoked by this specific acute inflammatory phase is at its absolute peak.
So by giving prophylactic AEDs for exactly 7 days, we actively suppress that early electrical irritability.
Exactly. We cover the peak of the storm while keeping the adverse medication effects as low as possible.
But hold on. If the brain is fundamentally damaged and that tissue is highly irritable, why wouldn't keeping a chemical damper on that irritability for a month allow the brain more time to heal?
That's the trap right there.
Like, is this 7-day window like prescribing a standard course of antibiotics where you just have to finish the pack to eradicate an organism? Or does the physiology fundamentally shift on day 8?
What's fascinating here is that it is fundamentally different from an antibiotic course. With antibiotics, you're hunting a pathogen.
Right.
But with post-traumatic AEDs, you're providing a temporary neurochemical shield during a specific time-limited storm.
Ah, so the acute inflammatory phase, that intense cytotoxic edema and glutamate dumping, begins to naturally settle down after that first week.
Yeah, the acute trigger for the seizure dissipates. Clinicians can be highly confident in this 7-day strategy because extensive pharmacological data clearly shows this precise duration works.
It effectively balances the benefits of seizure prevention with the rapidly escalating risks of medication toxicity.
Exactly.
So the acute chemical storm clears after a week, and you don't need to keep wearing a raincoat if the hurricane has passed.
That's a great way to put it. But clinically, it feels incredibly wrong to stop a drug that appears to be working.
Which brings us to the psychological trap that so many of us fall into on the wards, right? The illusion that more is better.
Oh, it's so common.
Because if that 7-day window is so incredibly effective at preventing early seizures, the natural human temptation is to assume that continuing the medication for another month is going to provide even more protection for this vulnerable brain.
It's the most common unforced error in neurotrauma management. The logic seems sound on the surface, but it's entirely flawed.
Extending treatment beyond that initial week does not equal better seizure prevention.
No, and in fact, it actively harms the patient's recovery trajectory.
Let's dig into that friction, because if you're standing at the bedside on day 7, well, wait, let me paint the picture. The patient is doing well, their intracranial pressure, their ICP is perfectly controlled.
Right, the swelling is down.
Yeah, the swelling is down, and they have had 0 clinical or subclinical seizures. The overwhelming instinct is, don't rock the boat. They are stable on this drug, let's just keep them on it until discharge.
I completely understand the anxiety driving that instinct, but the biological reality demands that we debunk it.
But doesn't extending the course help prevent late seizures too? Like, if they're still at risk for developing epilepsy months down the line, shouldn't we keep the shield up to improve their overall survival?
Extending the course of prophylactic AEDs does absolutely nothing to prevent late seizures. It does not lower the incidence of post-traumatic epilepsy, and it does not improve mortality in the slightest.
Wait, really? Why not? If the drug stops a seizure on day 3, why doesn't it stop the development of a seizure on day 30?
Because early seizures and late seizures are essentially two completely different disease processes masquerading under the same symptom.
Okay, explain that.
Well, early seizures are an acute, provoked reaction to trauma and swelling. We just discussed the glutamate storm. Late seizures, those occurring weeks, months, or years after that first week, are the result of a process called epileptogenesis.
Oh, so the actual structural rewiring of the brain.
Exactly that. Epileptogenesis is not just lingering electrical irritability. It is physical architectural change.
Like scar tissue.
Right. Astrocytes, which are a type of support cell in the brain, react to the trauma by forming dense physical scar tissue, known as glial scars.
And at the same time, surviving neurons attempt to heal by sprouting new dendritic connections.
Yes, but they often connect haphazardly, creating abnormal, hyperexcitable circuits.
And our drugs don't fix that plumbing, they just turn off the water temporarily.
That is the core issue. Most of our AEDs are sodium channel blockers or synaptic vesicle inhibitors. They stop neurons from firing an action potential today.
But they do absolutely nothing to stop an astrocyte from forming a physical scar.
Exactly. And they do nothing to prevent a neuron from growing an abnormal dendrite over the next 6 months. So giving the drug for 30 days does not stop epileptogenesis.
You're trying to treat structural remodeling with an electrical dampener.
Which means the only thing we're actually accomplishing by extending the prescription is exposing the patient to the side effects.
We're treating the symptom of the acute injury, not preventing the chronic condition of epilepsy.
And that exposure is not benign. The lack of a mortality benefit is not a justification for prolonged treatment.
Right, you hear providers say, well, keeping them on the medication might not help with mortality, but It can't hurt to be safe.
It actively hurts.
Mm.
You're taking a recovering brain, a brain that desperately needs to be waking up, engaging in physical therapy, and forming healthy new cognitive pathways,
Yeah.
and you're bathing it in neurodepressant chemicals,
You increase the risk of liver toxicity, profound cognitive slowing, and lethargy.
all without reducing the seizure burden by a single percentage point.
So what does this all mean for our day-to-day practice? It means the default posture must stubbornly remain at 7 days.
Absolutely.
But medicine is rarely one size fits all, and the human body doesn't always read the textbook. We have to look at the real-world exceptions.
Right. When do we actually break this rule?
Exactly. What are the clear, concrete clinical triggers that force us to deviate from the default?
The data outlines a few very specific, highly deliberate scenarios. First, we have to look at the patient's biological precedent.
Meaning their history.
Yeah. If you have a patient with a known, documented history of seizures occurring after a previous brain injury, the entire paradigm shifts.
Because their specific neuroanatomy has already demonstrated a lowered threshold. Their brain has already shown it prefers to react to trauma with epileptiform activity.
If we connect this to the bigger picture, extending prophylaxis beyond 7 days for a patient with a known history of post-traumatic seizures is entirely reasonable.
But that relies heavily on clinical judgment at the bedside, doesn't it?
It does. We don't have massive, multi-center, randomized controlled trials dictating exactly how many days to treat a recurrent TBI patient with a history of seizures.
The data is much murkier there.
So you have to weigh their specific historical severity against the current injury.
Let's shift from history to real-time events, because this is where the rapid response really matters.
Okay, yeah.
So if a patient actually has a seizure during that first week, say, on day 3, they have a generalized tonic-clonic seizure despite being on the 7-day prophylaxis.
Right, a breakthrough seizure.
We are fundamentally shifting our posture. We're moving from being a preventative security guard checking IDs at the door to becoming an active firefighting unit.
That analogy actually perfectly illustrates the pharmacological shift we have to make.
Right.
Yeah, a security guard at the door. Our standard prophylactic dose is just keeping the localized rowdiness from turning into a full-blown riot. But once a breakthrough seizure happens, a fire has started in the building.
The structural integrity of that neural network is now actively failing.
And you can't just tell the security guard to check IDs harder.
You need a continuous stream of water.
In clinical terms, the 7-day prophylaxis window vanishes entirely. You are no longer trying to prevent an event. The patient has actively demonstrated that their seizure threshold has been breached.
You're now providing therapeutic treatment.
Exactly. That means we're no longer just hanging a standard maintenance IV bag. We are pushing loading doses to fully saturate those receptors.
And urgently calling for continuous EEG monitoring to ensure they aren't slipping into subclinical status epilepticus.
Where their brain is seizing, but their body isn't showing it.
So the timeline essentially resets and stretches out indefinitely.
It becomes a long-term management strategy that requires neurology consultation and extends well beyond the acute ICU stay. The initial 7-day rule simply evaporates the moment an actual seizure occurs.
That makes the decision tree beautifully clear. But let's add the variables that complicate the wards, because we aren't just treating a generic brain injury in a vacuum.
No, never. We have to tailor this decision to the specific severity of the injury itself and the exact pharmacology of the drug we're choosing to use.
Let me push on the boundaries of this protocol. If these drugs are so incredibly protective against early seizures, why are we gatekeeping them based on injury severity?
It's a fair question.
Like, why shouldn't we just use this 7-day prophylaxis routinely for mild brain injuries, too? Someone comes in with a severe concussion or a very tiny microbleed. Shouldn't we give them a 7-day shield just to be absolutely safe?
It looks like gatekeeping, but it's actually strict evidence-based harm reduction. Injury severity completely dictates the clinical utility of the intervention.
So the 7-day benefit we've been discussing is only strongly proven for moderate to severe traumatic brain injuries.
Yes, those are the patients with massive glutamate storms and significant structural bruising. It is much, much less likely to offer any meaningful protective effect in mild cases.
Because their baseline risk of having an early seizure is already incredibly low to begin with.
The baseline risk in a mild TBI is so low that if you administer prophylactic AEDs, the risk of the medication side effects drastically outweighs any potential statistical benefit.
You're exposing a patient to systemic toxicity without actually preventing a probable event.
Therefore, routine prophylaxis for mild TBI should be strictly avoided. We aren't withholding care, we're protecting them from the cure.
Which brings us to the pharmacology factor, because the actual drug we choose changes the risk landscape entirely.
Tolerability is a massive piece of this clinical puzzle. Historically, agents like phenytoin were the absolute gold standard for TBI prophylaxis.
Right, but phenytoin works by heavily suppressing voltage-gated sodium channels, and it doesn't just do that in the injured cortex,
No, it heavily affects the cerebellum.
which means it carries a heavy, heavy burden of side effects.
Profound side effects. Because it suppresses global cerebellar function, patients develop severe ataxia.
So you have a recovering patient who suddenly lacks the basic muscle coordination to even sit up in bed or pass a swallow evaluation.
Furthermore, phenytoin carries massive cardiovascular risks during infusion, largely due to the propylene glycol diluent used to mix it.
Which can cause severe hypotension and arrhythmias.
And that's before we even mention Stevens-Johnson syndrome, a terrifying immune reaction where the epidermis literally separates from the dermis.
Wow. Contrast that with newer agents like levetiracetam, which we see used so frequently now.
Levetiracetam operates differently. It binds to the SV2A synaptic vesicle glycoprotein, essentially modifying how neurotransmitters are released, rather than just blocking the sodium channels.
It generally has a much more favorable physiological side effect profile, right?
Yeah, you don't see the same severe cardiovascular drops or profound ataxia. However, it absolutely comes with its own risks, primarily neurobehavioral.
Right, the infamous Kepper rage, where patients become severely agitated, aggressive, or experience intense mood disturbances.
The point here is that intolerance or significant side effects to whichever agent you choose is a major clinical trigger in itself.
If a patient is exhibiting severe ataxia on phenytoin or dangerous agitation on levetiracetam on day 4,
You do not stubbornly push through to day 7 just to satisfy a hospital protocol. Intolerance warrants an immediate bedside reassessment.
the drug's tolerability actively dictates your duration.
It's a trigger to shorten the course, taper them off, or carefully change the drug entirely.
Here's where it gets really interesting. We've built this logical, physiological framework. We understand the biology of the 7-day storm.
We know the exceptions for history and breakthrough seizures, and we understand how the pharmacology changes the math.
We know exactly what we should do. But clinical practice on a busy ward is messy. Providers are tired, handoffs are rushed.
Oh, absolutely.
So what are the dangerous clinical habits, the specific unforced errors that we need to aggressively identify and unlearn?
The biggest trap I see on the wards is pure, unchecked clinical inertia. Providers see a patient doing well on day 7 during morning rounds, and the thought process is, well, why stop a winning streak?
Extending prophylaxis beyond 7 days without a clear, documented clinical indication like a breakthrough seizure is our first major unforced error.
Do not let prescribing inertia dictate patient care. If they haven't seized, stop the drug.
Just one more week to be safe is a psychological crutch, not a medical strategy.
The second major error is indiscriminate application, treating the ICD-10 code for head trauma instead of the actual patient in front of you.
Do not reflexively order these heavy-hitting drugs for mild TBI patients.
Exactly, where the toxic risk of the drug completely eclipses the risk of the injury itself.
You have to stratify the risk before you sign the order.
The third pitfall is inappropriately applying broad population data to highly specific individuals.
Like if a patient comes in with a known history of post-traumatic epilepsy from a prior accident.
Right, you cannot assume they safely fit into the standard 7-day box. That requires highly individualized clinical judgment and likely a tailored extended plan.
You can't fit a complex neurohistorical square peg into a simple protocol round hole.
And what about managing the drugs themselves? This is the fourth trap. Switching AEDs without carefully weighing the side effect profiles.
If a patient has a minor twitch that isn't even confirmed as a seizure, and you impulsively change them from levetiracetam to phenytoin,
You're significantly changing the risk landscape for that patient's recovery. You're introducing the risk of ataxia and hypotension.
you must have a compelling, physiologically sound reason to take on that extra toxicity. And the final trap.
Relying on arbitrary timelines, deciding to treat for 30 days, or until outpatient follow-up, or until discharge, simply because it feels like a nice, safe milestone, is terrible medicine.
It exposes the patient to harm without any physiological rationale to back it up.
The biology does not care about your discharge paperwork.
That is a phenomenal synthesis. It really highlights how much of our job as clinicians is stripping away our own anxieties to follow the actual hard physiology.
So true.
So, to distill all of this down to the absolute golden rule, the framework you should carry on to your next shift. Use a standard 7-day prophylactic AED course to prevent early seizures in patients with moderate to severe TBI.
Only extend this duration if the patient actively has a breakthrough seizure, or if your clinical judgment strongly dictates it based on a documented prior history of seizures.
Then, at all costs, actively avoid routine prolongation beyond that 1 week.
That is the standard of care, clearly defined by the biology and the pharmacology.
Mm.
But, as is always the case in neurocritical care, solving one clinical problem just illuminates the vast darkness of another.
Yeah. So what does this all mean for the future of our practice?
Well, this raises an important question for all of us managing these patients. If our current prophylactic interventions, these sodium channel blockers and vesicle inhibitors we rely on so heavily, are incredibly effective at stopping acute early electrical storms.
But they do absolutely nothing to alter the structural scarring of epileptogenesis.
Right. What underlying mechanisms of long-term post-traumatic brain damage are we completely missing with our current pharmacological toolkit?
We are incredibly good at putting out the immediate electrical fire in the first week, but we have absolutely no targeted therapies to stop the astrocytic scars from forming or the abnormal networks from rewiring over the next decade.
We're staring right at the patient, but the long-term X-ray is still incredibly murky. The true preventative cure for post-traumatic epilepsy is still waiting to be discovered.
Something to mull over the next time you're reviewing those medication orders on day 7. Let the brain wake up, stop the meds, and keep looking for the real breakthrough.